Okay, it started. Hello, everyone. Good evening and welcome to our Myomunchee Zoom session. This is the second edition that we have done so far. And today we're really very honored to have invited so many experienced practitioners to be on this study club session. They will be sharing some cases and also after their sharing, if you've got any questions, feel free to use the chat box or use our WhatsApp group to post the questions, or you can unmute yourselves and ask the questions directly. And it's currently 8 o'clock in Australia, where most of our guests are from. So maybe a quick round of introduction to our guests. So in the order of their appearance today, first we have Dr. Dan Hansen. Dr. Dan, would you like to say a few words just so your main picture will appear in the main frame and everybody can see you?
Yeah, thanks Louisa for inviting me and everyone else onto this. I'm excited to see where this discussion goes, and it's really great to have the opportunity to talk to your people who you're in contact with over there in Singapore. I'm excited, and some of these wonderful people. There's one person on the screen that I haven't met before, so I look forward to meeting the people I can see who I haven't met, and then all these other wonderful people. We just spent the whole weekend together at our own course, so I feel like we've got this little family going on over here in this corner of my screen, and it's really lovely to see you guys again. So yeah, thank you.
Thank you. And so we've known Dr. Dan Hansen for quite many years now, ever since the time when he was a myobrace trainer. And now he and Dr. Donnie has started their own myofocus practice in Gold Coast and so in Melbourne. Yes. And Dr. Donnie, would you like to say hi to everyone?
Thank you, Louisa. Thanks for inviting me to join the meeting today. So my name is Dr. Donnie Mandrawa, and I'm the co-founder of Myofocus with Dr. Dan. And we started the clinic in October 2017, so it's not quite even 2 years yet. And we have now started the educational part of the venture as well. And we've been doing Myofocus mini residency, and we've just completed our orofacial myofunctional therapy course in Brisbane as well, in which we talk a lot about the Myomunchee system. So it's such an honor to be able to join the meeting tonight.
Great, thank you. And we also have with us Sharon Moore. So I have here a book that she has kindly passed to me, signed, autographed. And so Sharon is a speech-language pathologist. Sharon, would you like, introducing yourself and saying hi to everyone?
Yeah, sure. Hi, I'm Sharon Moore, and I'm the founder of a speech pathology private practice clinic in Canberra, Australia. And in our practice, we fully integrate myofunctional principles because we really believe that upper airway health, particularly in children, is really, really critical. And for us, chewing is a really big part of that, and that's why we use Myomunchee. And it's been really fun just spending the weekend with Dr. Dan and Dr. Donnie and Nathan there. So and it's really exciting to be able to share some of our work and a couple of case studies and seeing the interest that's coming in your region is absolutely wonderful. So thank you for having me.
No, thank you. It's really our honor to have such a star-studded cast tonight on the study club. And of course, Nathan, would you like to say hello to everyone?
Yeah,
Thanks
sure.
for coming on.
Hi, everybody. My name is Nathan Daney. I may have met quite a few of you just recently in Singapore, so it was really nice to do that. So this is a good follow-up. I represent Myomunchee internationally from a sales and a projects and partnership perspective. So I'm working on many different things at once, and have had an interesting background growing, in my experience in this field. Previously working with both Dan and a little bit with Donnie, actually, in a previous life at Myobrace. So it's actually nice that we've all teamed up once again. Also, I've got an extensive background coming from the sleep industry and also in pharmaceuticals, where I was working on a lot of screening programs. So I'm very familiar with processes, and really happy here to help from a business and implementation practical side of things as well tonight.
Great. Just to share with all of you, actually, the group that I have in this study club are people whom we are serving as part of Progressive Practices' role as the Asian channel partner for Myomunchee. And a lot of the practitioners are actually very new to the system. Some of them may have already started on Myobrace or myofunctional therapy as a whole even. But in general, they are pretty new to Myomunchee. While a lot of them are not right now on the study club, they'll be coming on later on or watching this on playback. I did ask if they had any questions prior to highlight to us, but it seems like, sometimes when you're so new, you don't even know what we don't know yet. So I would also like to appeal to the experienced users here on the group now. Later on, after the presentations, if there aren't any specific questions, then maybe for you to share from your perspective, if you can still recall what it was like at the beginning stages of utilizing Myomunchee, and maybe, amongst ourselves, let's preempt some of the questions that they may have, that would be useful for them. So and later on, Dr. Irene Lau from Hong Kong will also be signing in. So just to share with you, we're actually not only just having practitioners from Singapore, we also have practitioners from the Philippines, from Hong Kong, from Taiwan, from Malaysia, from Indonesia. Yeah, so it's actually various practitioners, and mostly are dentists or their team. But we also have some speech language pathologists and some other allied healthcare providers who are also starting to explore how they can implement the Myomunchee. Yes. And okay, Nathan just shared in the chat that Mary Book, the CEO of Myomunchee, will also be joining us in about 45 minutes time. Yeah, so this is a star-studded study club session. Great. So perhaps like we have discussed earlier, Dr. Dan Hansen, would you like to be starting with your sharing of your experience with the Myomunchee and perhaps a couple of cases of how we implement it?
Sure. And just so I can check, 'cause this is the first time I've done this in this way. I have keynotes on my desktop to share. Am I supposed to be doing that, or am I just talking about my experience?
Am I
supposed to share my desktop, or what's the?
Okay, maybe we give you like we give you for now. We can give you like 15 minutes, 10 to 15 minutes. So it's really up to you how you would like to present it. If you would like to show slides, I think, that would be good.
Okay.
Yeah.
Okay. I'll have to work out how to do that then, Louisa. Bear with me.
Sure.
I think
so at the bottom of the screen, there's a share box, right?
Yeah. Okay, got it.
So I think that's how you share your screen.
Fantastic. Okay.
Yes.
So let's see if this is working then.
Yes, we are seeing your screen now.
Great. You can see okay now?
Yes.
You guys can see okay?
Yes.
Fantastic. Okay. Cool. So yeah, thank you for this opportunity. I'm just gonna go through this. There's a few little slides we have, which are some of which are taken from the recent tour that I did with Myomunchee, with Mary and her brother Peter, who are both chiropractors, and also Sarah Hornsby, who's an OMT, who was with us this weekend. And unfortunately, my partner in crime, Donnie, wasn't able to be there. He was looking looking after everything back in Australia at the time. We a bit of a selection of stuff that we did in our recent USA tour, and also a bit from our weekend lectures just now. So I might just start with what I always start with, which is why I bother doing this treatment. So if anyone's new to considering myofunctional orthodontic treatments, really the reason I get up and go to work in the morning is because it's not so much anything to do with helping teeth be straight or things like that. It's to do with helping to reduce things like kids being bullied in school, and also to help children to sleep well so they can develop and grow properly and those sorts of things. So yeah, one of the reasons to treat early for me is to help minimize children being bullied in school, because we have lots of research telling us that that's something that happens. And the way Dr. Donnie and I work at MyoFocus is we actually combine Myomunchee with lots of other things. 100% of our patients will use a Myomunchee at the start of treatment. We'll combine that with quite an intensive orofacial myofunctional therapy program, at least for the first 8 weeks, before we consider using any other myofunctional appliances or any other type of appliance that we might use, such as an expansion appliance. So, for example, in a case like this, I would be the first thing we would do is teach some simple orofacial myofunctional therapy exercises and give this young lady a Myomunchee to start functioning and chewing on. And you can imagine if this sort of class 2 skeletal situation, if she starts chewing into a munchie, she's going to be chewing and frequently bringing those teeth forwards and functioning into this new position. And as the guy who was lecturing for MyoBrace for so many years, actually initially I thought the munchie, what's the point in using a munchie if I'm using a MyoBrace? That was my initial thought process. I'm a little bit ashamed to say that now, because I hadn't really given it enough thought. And what I found is that, of course, the Myomunchee is a myofunctional appliance. I always knew that, but I think I'd originally neglected the importance of chewing and actually functioning into that forwards position rather than just posturing into it and holding the jaw into it more passively, as you would in something like a MyoBrace. So what Donnie and I have found, and Donnie will share some cases later on, is that really the munchie combined with excellent OMT, it turbocharges treatment. It makes treatment happen a lot more quickly and a lot more effectively, and a lot more predictably. So yeah, this is why we do what we do. Kids get bullied early in school because of these sorts of things, and also they don't sleep so well. So the munchie is going to help with lip closure, bringing the jaw forwards, opening up the airway, encouraging nasal breathing, all the other things that we always talk about with airway and myofunctional. But functioning and chewing into that position is really the thing that the munchie is fantastic at. And Mary Burke, daughter of the inventor of the munchie, Dr. Kevin Burke, and sounds like she's coming on later, she always talks about helping the system to integrate. And really, when we're chewing, when we're chewing as compared to when we're just being passive into an appliance, there's a whole bunch of nerves firing and the whole system is working and the system is getting to integrate. And this is really, from a neurological and a neuroplasticity point of view, I think the munchie is fantastic because you're actually functioning into that position. So I'm not going to go into lots of research here, but I'm just showing you. I can't see that so well on my screen because you guys are in the, there we go. You guys are in the way on my screen, but that's okay. I can see it now. And if we play this through, let me go back one sec. If I play this through, so you can actually see the images, you start to see how the jaw comes forwards. And in these cases, it's just a 12-month process to get to that point. And the key for me, the key isn't that this is not a finished case. And certainly orthodontically, there are challenges with what we see here, that the teeth are ever so slightly tipped back and so on. Just so you know, this is not just munchie. This is munchie. This is MyoBrace. It's OMT. It's all kinds of other things going on. But this makes a tricky orthodontic case much more simple. And from this point, we can very, very easily make those teeth in the perfect position if we want to put braces on, or Invisalign more likely at the end of treatment. So it's yeah, it's a very useful thing to start working on kids early to make the treatment more simple, and also to not just leave them, so that they can start to function better and grow better early on. And Munchee is really a key way of turbocharging that for us. So I think you guys probably all know on this study group that sleep disordered breathing is a problem, and we know it's a problem for behavior as well. And children do get labeled in school because they're not sleeping so well. So really, really important to get kids sleeping well early on. That's kind of the reason why we do what we do. And another paper here talking about the critical role of myofascial re-education for sleep disordered breathing. So the importance of when tonsils and adenoids are being removed and sleep disordered breathing is continuing, really the importance of actually correcting the dysfunction that was there, which was part of the cause of the problem in the first place. So yeah, the Munchee is a fantastic way of sort of starting that and really turbocharging these things. And the great thing about it is you can actually do it from very, very easy on a 2.5, 3-year-old and even younger, sometimes younger, but 2.5, 3-year-olds will take to the Munchee much more easily than they will to almost anything else that I've tried them on. In fact, it's better than anything else I've tried them on because they just put it in their mouth and they want to just start chewing. You don't have to teach them what to do, they just do it. And my experience to sort of maybe preempt the questions like you said before, Louisa, is that using some of the videos that Munchee have got on their website, and we have it on our MyoFocus website as well, and putting that video on of other kids chewing on the Munchee in front of the child is a really good way of getting them to start copying other kids on the video, and give it to their parents and give their parents a Munchee and they can start chewing. And kids learn a lot by watching their parents, and many people like to talk about mirror neurons and things like that, about how we learn and we watch others and we copy them. And great to give the parent or the older sibling a Munchee to chew on as well. Have your own Munchee in your practice and chew on it with the kids, with the patients, get them in front of you and chew on your own Munchee, So really great thing to do. I don't think I'm going to have too much time to go through this. I'm just going to put the slide up, and when it gets recorded, you can always pause it. But it's just kind of where my mind is at with regards to all of these problems and where everything fits in and how it all starts. And perhaps in the future, we can take more time to talk about this slide, but feel free to pause it and then email me if you have any things to talk about. But I just want to talk about really one of the key things that puts people off from using these things is compliance. And what we've found is that if you build the practice or have areas in your practice that allow or help to facilitate good compliance, then you will get better results. So the vast majority of our patients, particularly the younger ones, when we're not having an active lab-made appliance in their mouth, so maybe they're just on a Munchee, for example, they will never go into a dental chair. The only time they would ever go into a dental chair is maybe taking some initial records at the start of treatment. And so most of our appointments will be done in a room like this. And we'll be asking them, have you worn your Munchee? Show me how you wear it. Really, really important, these sorts of things to do is say to them, show me how you wear it and show me the exercises that you've been doing. Don't just assume if they say they're wearing it that they're doing it properly. Always check, make sure that they're doing it properly. That was something I picked up from Sarah Hornsby this weekend. I do this anyway, but she really, really elaborated on the importance of checking for good technique of exercises. And that also goes for good technique of using the Munchee as well. So make sure the lips are together around it. Give them exercises to encourage being able to breathe through the nose easily. We taught a lot of that this weekend. Help them. If they're finding it difficult, there's a reason why they're finding it difficult, and then really try and empower them. Don't just assume that they're a bad kid because they're not doing it properly. There's obviously a reason why, and there's the skilled practitioner is quite artful in doing that. They're able to look at what's in front of them and work out what's wrong, and then help and positively reinforce, not negatively. So when they do something right, celebrate it. So the other type of way that we've built our clinic is this is our little orofacial myofunctional therapy room, which we call MyoFocus Airways. Bit of a pun there, and it looks like an airplane. And so we've got the cockpit there and the 737 windows, and teach the kids to chew the Munchee and do the exercises and so on in front of the windows or in front of a mirror. So we have this really nice space where we can do this, and it helps children to really be engaged in what they're doing. get down on their eye level, high five them when they're doing the right thing, those sorts of things. So I'm mindful of time, by the way, because I could go on all day. So please do let me know when I've got about 3 minutes, and I'll start to wrap up. Okay, I'm going to try and show you some cases, but do let me know, because I'm feeling like I might be getting towards the end of my time soon. So here's a young fella again. We see mouth breathing, which is low tongue posture, leading to narrow upper arch, the hyperactive mentalis muscle with that folded over lip there, which is limiting the forwards growth of the mandible. And of course, the mandible is relatively trapped within the underdeveloped maxilla as well. And he's a habitual mouth breather. So here in this case, this is a 6-month progress shot. And you can see this is quite nice. It's not a finished case. We've still got to wait for his adult teeth to come through. There's still a bit of dysfunction there. I can see underneath that lower lip, there's still a little bit of hyperactivity there. It's sort of, you can just notice that by that little crease under the lip. But he's not hardly ever mouth breathing, if at all, at this point in time. His tongue's resting in the roof of his mouth, and it's really going quite well. And given 6 months, that's really quite nice. And again, that's a combination of Munchee and a bunch of other things as well, other myofunctional appliances and really good OMT. And that's the key. Really good OMT is very, very important. So he was a 10-year-old mouth breather, reverse swallow. That was a 6-month progress shot. Really quick, going through another case. So we combine all this stuff with, expansion appliances. So for example, a BioBlock stage 1, the John Mew appliance. And you can see in this boy, he's a mouth breather. We did takeoff plus Munchee. We then, after they've gone through that initial takeoff program, we graduate them onto their MyoBrace appliance. And we move through the various different systems of OMT. We wait for the MyoBrace to be retained at nighttime. And all the way through, he'll be using the Munchee as exercises as well. So potentially for the entire sort of 6, 9, 12-month period, he'll be using that Munchee throughout as various exercises to help improve the OM. But eventually we provide a BioBlock, and here's his BioBlock in position there. And we expand. Once expanded, we're putting the MyoBrace back in again. Then he's going to graduate onto the next MyoBrace, the slightly harder one. And in this particular case, this is a 4-month progress shot, and you see that the lateral comes through rotated. And we do various things. We put the bent wire system in and use that, and that's helping again in combination with MyoBrace. And at the same time, we can be using the Munchee to keep the chewing happening and keep integrating the system, and really start working on the whole thing at the same time. Here we put the lower BWS in, and then we remove it. And you can see it's almost like playing a game of chess. We do one thing and the next thing moves, and then we work out what we need to do. So we put an upper BWS in to start changing that lateral incisor. We're starting to improve that now. Derotating. The lower Y is out, but that lower tooth space is still there. So it's a good test of function, because we would normally expect that to relapse. So that means the OM's going well. And by the time we get to this progress shot, we're still not finished, but maybe he needs some Invisalign to finish off, and maybe fixed is another option. But again, in these cases, no matter what you're doing, as long as there's not something in there that you literally can't wear a Myomunchee on. For example, fixed braces is a bit challenging. But if you're doing Invisalign, get the Munchee happening as well. Use the Munchee as an adjunct to whatever you're doing in order to try and improve the function. And that goes for even if you're just doing OMT. Have I got 3 minutes left or not? I can't hear you. Shall I keep going?
Yes, please keep going.
Okay.
I think what you're sharing is very invaluable. So yeah,
Okay.
we can give you extra time.
I don't want to go over my time, but okay, I'll keep going until you give me the signal. So this is a 6 years, 11 months, and we can see really quite significantly underdeveloped in the upper arch there, low tongue posture, creating that lower lip, keeping the mandible back, crowding the lower arch, not enough room for the upper or lower teeth. Very, very sick child, or nearly always sick. And we do some treatment which would involve our takeoff program, that initial intensive 8 weeks, using the Munchee all the way through that to start turbocharging things. Again, and then in this particular case, we would have done BioBlock 1. So we did here, MM means Myomunchee, we did OMT, we used MyoBrace, and we used an upper BioBlock 1. We did tongue tie surgery. We did not do lip tie surgery on this case. The parent wouldn't let me do it, even though I really think it would benefit because of the diastema. And I need to still make room for that 1-3. So we went back into the BioBlock. So this is the 24-month progress shot. We continue monitoring every 6 months, and she was still using MyoBrace and Myomunchee at that point. So yeah, this you can sort of see in that case there. I'm trying to see if I can see, because again I've got the thing in the way. You can see how the chins come forwards, the cheekbones are filled out. We've got space for the teeth happening, and this certainly is not a finished case. Just bear that in mind. It's a progress case. But again, using the Munchee all the way through this to really help integrate that whole. It's about functioning into that correct position, and the Munchee's helping us to function into that position, so that when we take the Munchee out and we start chewing our food, we're going to be having this habit and this training of starting to actually function into this more forwards position. When I say forwards, you can imagine if she was very class 2 and she's functioning all day long, or 2 lots of 10 minutes several times a day or something like that. If she's functioning into the Munchee in this position, when she takes it out and starts chewing her food, she's going to be functioning here. And when you function here, you start to grow here. And that's what we're trying to do. And I was amazed by the Munchee, because I honestly didn't think it was that important, given I was using a MyoBrace. I really didn't. And that was for years. And then when we started using it, we just started to see the changes so much more quickly. And Donnie will show you some of that later on. So I will just finish with just showing you this. Louisa has given me permission to talk about this. Otherwise, I wouldn't be doing it. But we're going to be teaching our mini residency, which is normally a 4-day course when done live. We're going to be teaching that on myocpd.com, which is a website that Dr. Donnie and I have created. And it's a website that's actually intended not just for us. So if anyone out there has got information to put on here, if you were to send us that in an MP4, we would host it for you and promote you, and you would also get your stuff out there as well. And of course, you would also get paid for doing that. But here you can see, if I go to online courses and then discount packages, you can get the four modules, which is normally the 4-day course. It's split into 30-minute sections, so you can basically stream it on demand at convenient times for yourself over the 8-week period that it's available. So you get everything's filmed in high definition. You get a CPD certificate. You get access to the forum if you join the whole course, which is a 4-week period where you can ask us questions and so on. The last 4 weeks of the course, the forum is on. And this one's limited to 50 people because we want to be able to really have a really good post-course forum so that we can ask all your questions and so on. And this is how you basically go through the website to join. So if you would like to learn more from Donnie and myself about how to use Munchee, but also how to do pre-orthodontics, this is a complete pre-orthodontics course. So the Myomunchee system really is about, hang on a sec, I've gone onto a different slide there. The Myomunchee course is about much more than the mini residency course is much more than just the Munchee and the MyoBrace. We're teaching BioBlock, bent wire system, forwards pull headgear when necessary, how to diagnose, how to implement it in your practice. We'll teach you a lot of our takeoff OMT. We won't go through the entire takeoff course, which is what we spent 2 days on doing this weekend. We'll teach you a lot of the OMT exercises, the core ones. We'll go through positive psychology, behavioral psychology, how to get good compliance, how to build a team correctly, all these different things. So please feel free to look at it. And if you have any questions, contact Louisa and she can always send them on to me as well. Thank you so much, Louisa.
No, I should be the one saying thank you. That was really a lot of information, and really, for anyone who would like to learn more. I think we are very fortunate that at least now this course is going to be made available online, and we don't have to fly all the way. Otherwise, we'd have to be flying all the way to Australia to be attending this. So, and I believe this is going to be just available for starting 1st of September. And do you mind sharing?
Correct. So you can register before. It's helpful to register before, but basically, and you could register actually on the 1st of October if you wanted to. But it's available from the 1st of September to the end of October for that 8-week period. So ideally, you would get access on the 1st of September. So you got the entire 8 weeks to watch all of these. It's around about I think it's about 19 hours, maybe 20 hours in total. But you stream it on demand, and it's split into half-hour sections. There's multiple choice questions at the end of each section, so that we can make sure that you've learned stuff correctly and those sorts of things. And then there's the forum afterwards as well. So it's basically our entire 4-day course online. Yeah.
And people will be able to access the videos at the full set of videos, right? Within that 4 months, would that be?
Within the 8-week period. Yeah. So 2 months, they can stream it on demand. Whenever they want to watch it, they can tune in. Maybe in the middle of a patient, or at lunchtime, or when they get home from work, whatever. They get access for the whole time. Yeah.
Right. Great. Yeah, I think that's we really have to, like what we are doing now on Zoom, right? We really have to utilize technology to to help us bridge that geographical gap. Yeah, but thank you so much for what you've shared so far. I just would like to, I see more participants have come online. So I just wonder if at this point, any one of you have any questions specifically for Dr. Dan Hansen and what he has shared so far, maybe some of the cases that he has shown and all. Because just to be mindful, for him and Sharon later on, they're going to probably be signing off around 9ish their time, because Dan has to wake up really early tomorrow So any questions, or if you would like to post the questions in the chat group or something? Anyone? If you have a question, you can also make a sign in the chat group, and then Melissa can unmute you. I see no one has any questions so far, right? Thank you so much, Dan. Please hang around until as long as you can, and I think later on when more people come on, we probably have more questions. But I really like that tip that you gave about getting the kids to use it, but also encouraging the parents and also even the practitioner. I think that's a really good tip. Yes, Dr. Has, I think, a comment here. So no matter what kind of active treatment, it's good to have 10 minutes times 2 times daily as adjunct.
Okay, so I guess I wouldn't want to put a complete blanket statement and say no matter what, because I guess there could be a whole heap of situations that I wouldn't want to say. A good mentor of mine once said, "Always remember never to use the words always and never." So I don't want to make a blanket statement on that, but most of the time. So if there's fixed brackets on there, that's probably a time where the munchie's not going to be so good, because you've got those bristles on the munchie kind of knocking against the brackets. But if there's another appliance in there that you can easily take out, or if the munchie's not going to affect that appliance, then good to do that. But it's not always a 10 minutes twice a day type thing. So for example, when we first give it to a child, you're going to celebrate 10 seconds. And it's just a case of giving it to them and being happy with them, just chewing it for a little bit. And it's a case of building up to that. So it's a bit like you wouldn't want to run a marathon straight away without any training. So for example, a TMD case, they can be great for TMD cases, but you don't want to ask a TMD patient to start chewing on these things for 10 minutes twice a day immediately. So you might do 30-second chew, and mixing it up, 3 chews on one side, 3 chews on another, then bilateral chewing, then rotatory chewing. There's all kinds of different ways of using it. But so no matter what kind of active treatment, but no matter what kind of orthodontic treatment you're doing or TMD treatment, some kind of orofacial myofunctional therapy is going to be helpful. And the Myomunchee can help as an adjunct to that, in helping all of that process move along. So softly to begin with, start gently and work up to that, and be mindful if there are symptoms coming in, for example, in a TMD case, then maybe they're doing too much.
Dr. Kong, does that answer your question? But I think really what we have found in our own practice also is that, where...
Yes, thank you. Yeah, I understand. Thank you very much.
Thank you, Dr. Kong. Yes. So in our own practice also, we are realizing that the Myomunchee's benefit is really that it's softer. So it's a very good first appliance for them to get adapted before they move on to any other appliance. And also, really the act of chewing itself is the active treatment. But again, it varies from person to person. Thank you so much. Any other questions from anyone? Otherwise, we'll move on to Sharon.
Hi. Is it okay if I share a few slides as well?
Yes, please. You know how to do the sharing, right?
Yes, I do. I'll just do this first, and this one, and play from the start. Have you got the screen on? Can you see that?
Yes.
Can you see that? Okay. Okay, so I'm actually working with 2 computers, but we'll be right. Okay, so I really love the way Dr. Hansen starts with why, because I think it's really important to understand why we do chewing in the first place, and then why would we chew on the munchie. And because I'm a speech pathologist and I work with a lot of medical and dental specialists, we really focus in on upper airway functions and then dysfunction. And if we look at function, chewing is one part of that, but it's a critical one for developing upper airway health and growth. So we see chewing as a key player in the upper airway and also the sleep puzzle, because upper airway health in the day plays into, in many ways, upper airway health at nighttime. And we know that breathing during sleep is really critical for healthy sleep. And we'll just spend a little bit more time on that. Anthropologists are telling us that diminished jaw growth results in limited space for eruption of the wisdom teeth. And I think we hear people talking about this quite a lot, and that leads to malocclusion and the relationship to sleep disordered breathing as well. So I think that's important. And why use a munchie? Well, I think firstly, in a clinical setting, when we're looking at function and upper airway function, we want to identify, when is it happening correctly, and when is it not? What are the signs that it is not functional, that it's atypical or dysfunctional? And then how do we correct that? How do we optimize chewing? And what are the appliances that we use, and what's our ultimate aim? And really our ultimate aim is to have kids chewing in daily life. And we always talk about the 70% rule. And the 70% rule means 70% of food that we eat every single day should be chewy or crunchy. Now, if we look at the upper airway, we see so many different parts of the upper airway. And chewing clearly is one of them, and it's very, very important. And if we're talking clinically that we want to improve chewing, in my experience, and certainly what we do in our clinic, is we don't correct chewing without correcting breathing and swallowing as well. So it is definitely integrated into the upper airway system, functional system. We also know that chewing has changed in society. So we chew less, we chew faster on predominantly soft food diets, and we make less nutritious choices. We use a lot of tins and packages and processed foods. Breastfeeding practices have diminished since, pre-agricultural times. And all of these things really contribute towards changes in the way we think about chewing in everyday life. And it's those anthropological characteristics, those changes in the way we do chewing that are meant to account for diminished jaw size in today's society. And I think it's important to keep that in mind. But what are the benefits? Well, the benefits of chewing are many. It influences bone growth, cranial bone growth. It influences growth itself. It prepares food for digestion and kickstarts digestion. It facilitates drainage of the sinuses, drainage of the eustachian tubes. It increases blood flow to the brain. Comminution, it's the ability of chewing to break down food particles that helps combine the food with saliva. It pumps the salivary glands, it reduces cortisol levels, relieves stress, improves alertness, improves cognition and memory, and also very possibly stimulates major hormones in the body because of its very close relationship to the pituitary gland. So, just having a little chewing dysfunction. So what can go wrong with chewing? Pretty much everything in terms of the morphology and function of that upper airway, particularly the orofacial system, anything that is atypical in that area may impact chewing. But one of the other things that I see daily in the clinic is that even when there's not a severe or even a dysfunction or a disorder that we could diagnose, that we see really poor chew habits in daily life developing. And that's certainly one of the focuses that we have in the clinic. And here are a list of quite some of the things that might be associated with poor chewing. So frequency and intensity means that it's not happening often enough or intensely enough. Morphology might mean that there's skeletal asymmetries that make chewing difficult. Dental health issues like missing teeth or pain in the gums might influence and cause poor chewing. Intra and extra oral function might refer to the fact that kids might have hypotonia or weakness in those muscles that make chewing effective. We certainly know that when chewing is not effective, we get compensatory strategies happening. And I've got that word audibility there, and really by that I'm referring to poor chewing is often really super noisy. And other things like underlying medical diagnosis like Down syndrome or, upper airway tract infections and things like that can influence the effectiveness of chewing. Kids with developmental delays and intellectual delays often will have trouble with chewing. And then right at the very end, we have environmental issues that can impact chewing. And that can be something as simple as the whole family chews with their mouth open. And so if they all do, there might be nothing physiologically wrong, but that it's just a family habit. So let's have a look at a couple of case studies here. This one is a little girl with a syndrome called Coulant-de-Vries syndrome. And she first came to me when she was about 7 years old, and her family was most concerned about her drooling, which was related to hypotonia. but more particularly her messy eating and her open mouth look, because these kids have hypotonia and that muscle weakness. They would be, you would expect those things. But her parents were really concerned, not so much when she was 7, but what was going to happen when she was an adult. So they were really forward thinking about her development. She actually has a really severe speech problem, much of her speech is unintelligible, but she has a myofunctional problem as well, which was severe. So very, very low tone. Although you can't see it in this picture, she often has her tongue in an interdental position. She's unable to fully elevate her tongue. She has a tongue thrust swallow and lots of drooling. And in terms of morphology and that dental background, she has hypodontia, 7 teeth missing, and quite a significant anterior open bite. And so with her, we did start on the Myomunchee straight away. And the reason that we didn't do that was because she was unable to get lip closure. But part of our recommendations was exactly what Dr. Hansen was also describing, the importance of myofunctional training, helping the muscles in the mouth and the face and the throat to normalize function. And part of that is just control of the musculature. And then when we have that under control, we have to integrate that into swallowing, chewing, and breathing. And that's where the Myomunchee became part of her program. But the first thing that we did is that we actually got her onto quite a thick chew noodle. And we got her chewing on there to help to strengthen the musculature. And after about 12 months, when she was getting really consistent lip closure, then we started her on the munchie. And she just loved this munchie so much, we could virtually not get it out of her mouth. And that actually became a problem because Mum started using it as a bit of a babysitter in the back seat of the car, thinking, oh, double task. She can do it in the car while I'm driving. But unfortunately, when that was happening, she was using it without the lip closure and managed to destroy the munchie. So I think that's in terms of tips for beginners, it's really important that the technique with the Myomunchee is really good. And so if a child is only able to maintain that lip closure for, say, 10 seconds, initially you would only put the munchie in for 10 seconds. And what Dr. Hansen was saying as well was, there's no hard and fast rules. We try to help kids work towards 2 times a day for 10 minutes, but sometimes it takes a while to work up to that. And every child is a little bit different. So, we treat them like that. And so sorry, I'm not showing you the videos because I'm just a little bit cautious about the videos being shared and about patient confidentiality. So we'll just go on to this little guy who was 5 when we first met him. And he has a background of cleft lip and palate, speech disorder and a myofunctional disorder. He's 5 in this picture. His morphology, well, he has a very narrow maxilla, a displaced premaxilla, crossbite, overbite. He also has quite a severe tongue tie. Functionally, he has a lot of neck and jaw compensations. He has mouth breathing, a tongue thrust swallow, and open mouth chewing. He also, he was very restricted in what he could do with his tongue. He had what we call hypernasal resonance, which is not unexpected with a child with cleft palate. Although he'd had the cleft repair, the soft palate wasn't functioning as well as it possibly could be. So that was one of the things that we had on a recommendation for him. Also, his limited tongue mobility really made it hard for him to eat normally. So he developed a lot of food fussiness. And so in his recommendations, it was correcting the breathing, the chewing and the swallowing, And part of correcting the chewing was definitely the chew noodle and the Myomunchee for him. And yes, despite the way this occlusion looks, we were able to fit him with a Myomunchee. We also worked on speech correction and velopharyngeal closure, and we recommended a frenectomy and also some expansion for him. And his team had a fantastic family team. He had an orthodontist, a dentist, cleft palate team, an ENT, and myself. And unfortunately, his progress stalled because the dental and the medical team didn't agree with the frenectomy or the expansion on the maxilla, which was a shame. So in the meantime, we've just pressed on with using the munchie and working on his improved feeding with nutritional intake. But we see the Myomunchee as a really critical part of his treatment. And here's yes, I can't show you that video, sorry, but that was Samuel, who was a 7-year-old, and he was a much more straightforward case, 7-year-old with some low tone in the upper airway, and we were using the Myomunchee to help him develop the strength in his upper airway musculature, and he was really successful, and the Myomunchee was a very, very straightforward part of his program. And this is a little 3-year-old, so I might just say here that the youngest child we've used a munchie with in our clinic is 18 months of age with a Down syndrome child, and that was absolutely a fantastic thing to do and became part of his everyday myofunctional strengthening pattern. It's really important for kids with low tone. Now, this little guy, I'm going to talk about him because he's a tricky case, and I think it's handy for beginners to know about tricky cases. 98% of the kids that we give munchies to do really well. Our biggest problem is getting it off them because they will often try to over-chew. Anyway, we'll just come back to little Joe. Joe was 3, and we saw him just post-tonsil adenoidectomy and had a strong history of sleep-disordered breathing. His family was really, really concerned about the persistence of mouth breathing and the fact that he seemed to have a very, very tiny mouth. He was also making a lot of speech errors which weren't typical of his age. So what we recommended for him was to do one of our Foundations Myo courses, and that we usually do in a group setting. We will often put somewhere between 3 and 6 kids together with their families, and this also harks back to what Dr. Hansen was saying, that it's really great when you can get the whole family doing munchies together and doing myofunctional work together, because our most successful cases are when the whole family gets involved. And this certainly was the case. Little Joe turned up to sessions in the group with his dad and his sister, and with myofunctional therapy alone, we had these changes from this anterior crossbite, which almost resolved just with myofunctional therapy. And so our next port of call was to get him onto a Myomunchee, and that just turned out to be a little bit tricky for us. Sorry, I'll just go back to that. It did turn out to be a little bit tricky because he was the first little man with no warning to us that he had a very hypersensitive gag. So even though we'd been in his mouth and doing lots of things and doing chew noodles and doing myofunctional therapy, when we put the Myomunchee in, for some reason he threw up on that day. And so we just waited for a while and got him back onto chew noodles for a while. And very shortly we will go back to Myomunchees because we see that as a really, really important part of his upper airway functional program. And so in our programs, we establish nose breathing first. There are these critical parts of getting to chewing and upper airway function. You need to have nose breathing. and you need to be able to establish good oral rest postures, which are tongue up, lips together, and back straight. You need a straight spine, and that needs to be encouraged through all the chewing programs, including with the Myomunchee. We do at our practice teach a sequence for exaggerated chewing right in the beginning, and we have a series of set stages that we go through with that, and we always use, like Dan said, we always use chew appliances, and most of the time that is Myomunchees and or chew noodles, and we just think they're fantastic. So how am I going for time, Louisa? Am I up for time?
No worries. If you can just just go on. And do you have quite a few more slides, or you just
No, I'm very close to the end, but I don't want to keep you too long if I've taken up.
No worries. I'm really grateful that all of you are just sharing so much information. I think this is very important, especially coming from the speech language pathologist angle. So just please go on and until you reach the end of your slides. Thanks.
Okay, we'll do a few more. The honour's all ours, Louisa, honestly. We have so much to share. There's so much. This is like the tip of the iceberg. But let us know what you'd like to learn, and we'll bring it. Anyway, in our clinic, you have to make therapy fun. So, we talk about the rules to success in therapy, and Dan and Donnie and the programs that they run are geared exactly this way. And there are many ways to skin a cat. Do you have that saying? Do you know that saying? Yeah, there's many. There's lots of ways to do it. And in our clinic, we actually get into real food, because our final aim is that we have kids chewing 70% of their daily food, crunchy and chewy, and that they chew really well. So we do stuff like this, it satisfies the artist in us and the creative beast. But the kids find this enormously fun, and they also are able to do this kind of thing at home, and it gets kids involved at home. And we make rainbows, we make palm trees, depending on the season. We make Christmas trees. We introduce textured food really early in the program, so you see lots of dried fruit and crunchy fruit here with this guy. The kids absolutely love it, and they're really proud of these creations that they make. We're always, at every step of the way, we are looking at our progress and measuring baselines on their nose breathing and their lip seal, and how they're managing their saliva control, how their other muscle functions are going. So we're always looking at swallowing and breathing in conjunction with chewing, and of course symmetrical chewing is key. Now, we found in our programs that we have to teach the correct swallowing anchorage, even with Myomunchee in. That's just our experience, but we do that and reinforce that along the way with our programs. And here are some other general tips. When you're working on chewing with real food, and you've been using the Myomunchee along the way to get to that point, the most important thing is to stabilize the chewing, and to stabilize, and that's about stabilizing the mandible. We also teach kids to count their chews. Otherwise they go munch, 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 swallow, munch, 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 swallow. And actually to make food liquid or mushy, which is the word that we use, we get them counting their chews to make sure that food is liquid before they swallow it. We work on symmetrical chewing, whether that's focusing on the right side, then the left side, or both at the same time. And then as part of that chewing, we always talk about catching a smiley swallow. And that's just part of integrating something they've already learned with us about how to do a palatal anchored swallow instead of a tongue thrust swallow. We also help kids to understand that while they're chewing, it's important to chew longer, because their mouth talks to their tummy. And kids find this fascinating and think it's hilarious, and it's actually true. So, and then the ultimate aim of that then is integrating those chewing techniques into everyday life. So as soon as we can, we get them using good chewing with every snack and every meal that they do, and the whole family's involved. And we keep the Myomunchee going both passively and actively. Do you know what I mean by that, passively and actively?
As not chewing?
Yes, exactly. When we say using the Myomunchee passively means helping kids to put the Myomunchee in their mouth with proper lip closure for longer periods of time. And that might be when they're doing something else, or a quiet activity like drawing or craft or watching their favourite show. And you can leave that in for a lot longer period of time. So the active chewing is when they're doing the chew, chew, chew action on the munchie, and that's where we're aiming for the two times 10 minutes a day. But the passive chewing, you can definitely do it for longer. And Dan and Dr. Hansen and Dr. Mandrawa also recommend it's used at night for some kids. So they might talk about that themselves. But I think that's all from me, except this is Bruce, the friendly shark in my clinic that kids love, and he encourages them to chew. And yeah, thank you so much for letting me share my work. Thank you.
So much. Yeah, that was an eye-opener coming from this angle. I do have a couple of questions for you, Sharon. You mentioned earlier that over chewing, can be a problem. Can you elaborate on that?
Do you mean over chewing with the munchie?
Yeah, or yeah, because you were saying that sometimes it's like it's not about the difficulty in getting them to chew, right? But it's that they end up over chewing. So
yes. I think particularly in the early stages of chewing with the munchie, they definitely need supervision. So they need supervision for two reasons. One of them is that they're doing the technique correctly. So, and the main part of that is that they're nose breathing, and also that they have really, really good lip closure. What's the other reason? I just had a mental blank. Sorry, give me a second. So, yeah, they need supervision, because if you leave them alone, just watching TV, for example, and just chewing on it, they get distracted by what they're doing and they stop chewing properly. So I think it's really important to watch them and make sure that they've got that technique going. Otherwise, they're not getting the full benefit from that. And the other thing is, if they start chewing incorrectly on it, you can damage the device. So the young girl with the syndrome who I presented as a case, because she was using it in the backseat of the car and wasn't supervised, she was getting a lot of pressure on the molars on the back of the device, and she just completely chewed through it. And it took us a little while to work out exactly what was happening, because mum didn't know, because the mum wasn't watching her. So that was a real lesson for us, to make sure, especially probably with a lot of kids like that need the supervision.
Right. So it's mainly to make sure that they are chewing properly, right? Even for myself, when I first started out, I think I was over chewing, in a sense that I was really gnawing at it, and I was having some, sore in the palate. And until I realized, speaking to other practitioners, that actually it was just supposed to be like more like a mini chomping.
Mini chomping, yeah. Actually, that's such a great point. Yes, kids can get sore on the gums. And so usually, we start out little bit by little bit. We say, is that okay? And then we have a look at their gums to see if there is any red spots or rub spots, because everybody's mouth shape is a little bit different, and you can trim the device. But in terms of now I understand what you mean by the chomping, like you were really chomping. That's called dinosaur chomping. So in our clinic with the kids, we have bunny chomping, pussycat chomping, and dinosaur chomping. And so we practice all three so they know what all feels like, and we're really looking for the pussycat chewing, which is like the just right.
That's great.
Yeah.
So Dr. Eileen has a question posted here. How do you guide a toddler of 18 months to use the Myomunchee correctly? Because they might not be able to follow the instructions as well, right, as the older kids.
Well, Dr. Hansen said when he was talking that you show them a video, or that you put them with other kids or the mum or the dad and show them, and you just do it for short periods of time. And if they're not able to keep their lips together, you can do a manual assist and say like this. You can show on yourself how to keep the lips together, or you can show on them how to keep the lips together. And you really just start doing it for very short periods of time. I think that's the key until they can do it properly and they get that technique and they're using the technique well.
Right. And for your Chew Club, I really love how you presented the food. It's like, oh, looks so good. What would be a average like number of chews per mouthful? Is there like a range? Like maybe like, is it like 20 to 30? Like if below 20, is that too little? And then, 20 to 30 is like the average, would you say?
Yeah, it depends on the texture of the food. So we will start with softer foods that require chewing. So if you think about banana and strawberry, 20 chews is probably too many, but it also depends on the size of the mouthful. So some kids will take that size and some kids will take that size. And so you play it by ear. But with the softer foods, I'd say around 15 to 20 chews per mouthful. But when you start, looking at dried fruit and really crunchy apples and crunchy celery and carrots, that is really 20 to 60 chews. And some of the kids get so carried away and they actually love doing it. Sometimes they over chew and do too many, but they'll get up to 60, or they think they're special because they got up to 80. And then it truly is liquid by then. But, this is all part of the fun of the group. And I think, they'll do that. And then you'll say, well, why don't we try and do that in 40 this time? And let's check. And sometimes we do a chew check, which means opening their mouth and showing us, which is a little bit gross, but, you can see. And we do checks to see, after they've swallowed, is there anything left over in their mouth? And if there is, then we do the tooth cleaner with the tongue to catch all those other pieces and chew them up again if they need.
Yeah, that's an excellent idea. Dr. Pang has a question. What is a smiley swallow?
Okay. Okay, so when we teach a palatal anchored swallow, instead of, in place of the tongue thrust swallow, we've already done all the preparation bridging exercises. And what that means is that we've gone into suction hold, like that. Then the teeth gently close and the lips close. Sorry, the lips don't close. You smile and show us your teeth, and you swallow and keep smiling, and the tongue has to stay there. So it's an advanced part of the program. It takes a while for kids to develop that if they've got a tongue thrust swallow, but they all know what it means. If they get to that stage of the program, they know how to do smiley swallows. And it's very important that the tongue is still not dentalizing or pushing forward in any way at that point in the program.
Right. And then you're talking about the different chomping. So basically, rabbit chomp is really a little bit too tiny.
Yes, yeah, not enough strength in the muscles.
That's
yeah.
Right. And then the pussycat one is like the just right.
Yeah,
and then,
that's just right.
And then the dinosaur is the very exaggerated one that will destroy the munchie.
Yes, exactly. Actually, you just reminded me of something else. We do talk a lot about posture as well. And so very often when kids start chewing on the munchie or they start chewing on food, you'll see them going like this. And we use a lot of music in our program, so they like to do this anyway. But we always encourage the parents just to gently place the thumb and the forefinger just at the base of occiput here, just very gently. It's not a push or a press. It's just a very gentle hold. And we talk to them about just letting their mouth do the work without their body helping. And kids really respond to that as well. And that helps to stabilize some of those muscle compensations, because we really want just the mouth to be chewing.
Right.
Again, it's a work in progress over time, and it's one of the beauties of putting kids together in groups, because they see each other doing it, and all the parents see the other kids and the other parents doing it. Half the parents struggle with it as well. But they're a lot of fun. They really are a lot of fun.
Yeah, thank you. Thank you for all that wonderful sharing. And we really hope that, one day in a not too distant future, we'd be able to invite you, Dr. Dan, Dr. Donnie, over to Singapore to conduct the course live over here. And we'll have the practitioners from all around the region to come. And I think in Asia, it's still really at the very, beginning stages. And I'm, still, even locally in Singapore, we're still trying to recruit more and more speech language pathologists or speech therapists on board, because you know for yourself, right? Your original training in university did not cover a lot of these orofacial myology dysfunction or myofunctional therapy component, right? And there was a lot of extra research and studies, right? And so we, in a way, we are not getting that kind of support which we hope we would have. And so we have to train a lot of our own staff, our own team members, to be the myofunctional educators, we call them, because we know it's a different level, that the SLPs do, and the well-trained myofunctional therapists do it. And we're really hoping that we can really get a bigger group that can help the kids out there.
I love your work, Louisa. Keep doing it. It's so important. So I just thank you for having me, and thank you for all the work that you're doing. So we're very happy to share anything that you need. Let us know.
Yes, I'm sure, because more people have come on. I think we now have like 28 participants, but many more will be watching the playback, and I think they will, like us, know and see the value of what you've been sharing. And if we could really, I think we will hope to be able to, in the near future, invite all of you back on again, to share more, and really eventually run your course in Singapore. I think, that will be excellent to be able to see you face to face. So thank you very much. I'm mindful that it's already past 9 o'clock for you in Australia, for yourself, and a bedtime, and for Dr. Dan also. So any last questions, anyone, before Dr. Dan and Sharon signs out? But not to worry, Dr. Johnny's still here, and Nathan is around, and I'm not sure if Mary has come on yet, but we still have a lot of experts on the panel for questions, and Dr. Irene has also come on, and she will be sharing too. So any last questions or comments, anyone? Okay, so Dr. Donnie has gone off to tuck his daughter into bed. So Dan is still around. Yes. Any questions so far? Any further questions? I think we will definitely chew on all the information that you have given us. It's very generous sharing, and I really want to thank the both of you. And we've got okay, Dr. Donnie is back. Hello, welcome back.
Thank you.
Yes, so we'd just like to say thank you and good night to Dan and Sharon, and I hope that we can have you back on the study club someday soon again. And like I said, eventually we hope to be able to run your course in Singapore. Yeah, that would be fantastic. Yeah, but in the meantime, there's still the online course portion. So thank you. That was really very, very excellent sharing. Thank you, Dan, and thank you, Sharon. Okay, I think Sharon has signed off. And Donnie, would you like
Yes.
to start off with, yeah, I believe you have some cases that you can actually be sharing with us.
Yes, that's right. Can you hear me properly?
Yes.
Is that okay? Yes? Okay, excellent. So what I'm going to do is I'm going to follow up from Dr. Dan's talk before, and I'm just going to share my slides of case studies and giving everyone a little sneak peek of our OMT course and our mini residency. So there's a couple of case studies that I'm going to share tonight that that we have been sharing when we present our courses. So I'm just going to do the sharing of my computer screen. Okay. So thank you again, Louisa, for inviting us to join the study club tonight here. Can you see this, my screen quite okay there? Yeah, excellent. So what I'm going to share tonight are two case studies, two quite different age group as well, in which we manage both of them using our myofocus philosophies. So the first one that I'm going to show you will be a 10-year-old. Sorry, my slide's not actually moving. Just trying to fix my slide quickly. Okay, here we go. So the first one that I'm going to share with all of you tonight is a case of a 10-year-old, and then I will go on the 2-year-old as well, in which we use the Myomunchee in both cases. Just to explain to everyone before I go into the actual cases, with the myofocus system, what we do for every patient that are old enough to understand and to have a better level of compliance is we would start them off with what we call the myofocus takeoff program of orofacial myofunctional therapy. So the takeoff program, Dr. Dan and I designed that because we believe that from our past experiences, the orofacial myofunctional part of the whole treatment is probably the most crucial and the most important in order to get the success rate higher and in order to get the results even much better and much quicker as well. And the way we designed the takeoff program is we also have compliance in mind, and not only regarding the design of our clinic that Dr. Dan already mentioned before, but in terms of the type of exercises that we do with the children, with the patients, and how often we see them. And what we find is with the takeoff program, the compliance level has elevated quite significantly compared to the way I used to do my functional therapy in the past. So the first patient is our 10-year-old patient. Now this patient, he was actually almost 10 years old when I saw him, and he was in the spectrum, and he couldn't really even put a few words together in one sentence. So couldn't really hold a conversation with me, couldn't even look at me in the eye. And if you look at the operative photos, you could see that his frontal view photos at the top there.
I'm not looking at your screen right now. Are you able to share your screen again?
Oh, okay. Let me see. Can you see the screen?
Yes, I can see it now.
Okay, if I play a slideshow, I think that's where I lose it. So I'm just going to go down the actual order of the slides itself.
Okay.
Yeah, so so there was a takeoff program and now the 10-year-old. So this is the initial photos of the 10-year-old who was on the autistic spectrum. And when initially I met him, he couldn't even put a few words together in one sentence. So he couldn't even hold a conversation with me, and he couldn't even look at me in the eye at all. And when you look at the pictures, the initial pictures of his extra oral photos on the left-hand side of the slide there, the top photo is his resting posture, and the second one is his lateral profile posture, and the bottom one there on the left is his smiling posture. So you could see that there was really not that much difference in terms of the mouth posture between resting and smiling. So he had pretty much quite a significant lip incompetency, mouth breathing as well, and he had quite significant overactive buccinators, so those are the cheek muscles, and overactive mentalis, which are the muscles under the lower lip there. And with such overactive facial muscles, what he was experiencing was when he was functioning, when he was swallowing in particular, his buccinators and all these facial muscles were putting forces from the outside inward, which was causing the maxilla to be quite restricted. So you could see the photo of the maxilla on the second column, the top photo there. It's quite a V-shaped maxilla with a high palatal fold as well. And on the middle photo of where he's biting from the front, you could see that the posterior segment of the maxilla are pretty much inclined inwards, and the lower posterior teeth are also inclined inwards because of the forces of the buccinators going against those teeth. And when you look at the lower dental arch itself on the very bottom photo, you could see how much dental crowding there was at the beginning. And he actually also had a lingual frenum restriction as well. Now, so those are pretty much a lot of the findings that we found during his initial consultations. And from there, we would take full orthodontic records, which would consist of obviously a lot of photographs, and we also take videos of him functioning, and also radiographs, which consist of panoramic x-rays and lateral cephalometric and a frontal AP skull as well. We also take 3D digital scans of his dental arches and his occlusion. And from the record taking, then we're able to analyze the records and do up a treatment plan for him. So after having gone through all the record taking and the analysis, then we actually created a treatment plan for him. And the treatment plan went along these lines. We were recommending for him to see a body worker, so a manual therapist, like a pediatric osteopath or a cranial osteopath, or a pediatric neurodevelopmental chiropractor, who could help him with his posture, as well as releasing a lot of other bodily restrictions. You can see with him, he's got a forward head posture with the neck pretty much angled quite significantly forward there. And I was also considering breathing retraining, like a dedicated breathing coach for him to see and be managed by, simply because I was thinking that his mouth breathing was actually quite significant. He was constantly mouth breathing. And then we would start off with the MyoFocus takeoff program for 8 weeks using myofunctional tools, including spots, Munchee, and the lip trainer. And we would also be releasing his lingual restriction using our water laser. And the way that we design our takeoff program at MyoFocus is we would do the actual restriction release between the 4th and the 5th visit of the takeoff program. And our orofacial myofunctional therapy itself, we have a whole prescriptions of the exercises, in which we, by last count, we have actually about 72 prescriptions or so, and there are 3 variations of each prescriptions. And so at each visit, what I would do is I would look at where the dysfunction is at during that visit and work out which prescription would suit him best. Because what we believe is it's not just about treating one dysfunction, but also about treating all the dysfunctions that we could see at that point of time of the patient. Especially during treatment, when the treatment is progressing, things do start to change quite a bit, and things can change quite rapidly as well. So the practitioner needs to be very skilled in terms of picking out and diagnosing what are the dysfunctions at that point of time. And oftentimes what I find is when there's an obvious orofacial dysfunction, when we are treating that particular dysfunction, other dysfunctions become more obvious later on, in which we've got to also manage those as well. So we've come up with our prescriptions, the MyoFocus takeoff prescriptions, that would help us to decide the type of exercises that we would prescribe at each visit of that patient. And we usually go into the prescriptions in more detail during our orofacial myofunctional therapy course, which we've just completed on the weekend in Brisbane. But the treatment plan for this particular boy, as you can see on the screen there, I was even planning for using extra expansion appliances like the BioBlock. And I was also considering braces or even aligners after it, because the severity of the case is quite significant. So what happened when I actually performed the treatment? He did see the body worker, so he was actually being managed by the body worker once a week at the beginning, and then it got cut back a bit to every fortnight, and every month, and then every 6 weeks when it came to the later stages of the treatment. And he did the MyoFocus takeoff program for 8 weeks. He had the lingual laser frenotomy in the middle of the takeoff program, continuing on with the OMT with the MyoFocus prescriptions. And he had MyoBrace K1 for 2 hours daily while awake, and K1 to sleep at night. Now, I don't like to say K1 day and K1 night, because day, a lot of patients just consider that and link that to daylight. So I tend to say to patients, it's K1 while you're awake, 2 hours while you're awake, not during the day. And once he managed to keep the K1 to sleep every night and staying in every night for about a month, then he changed to K2. And once we believe that his orofacial dysfunctions have all been corrected and are stable, I actually put him on a K3 for night retention to sleep and review him every 6 months. So in this next slide, there are quite significant differences that you can see between the pre-operative photos and these next lots of photos. Now, these next lots of photos, you can see that his lips become more competent. His head posture has started to improve. The maxilla has widened quite significantly. The bite has actually opened up from the deep bite. And he actually even had a little bit of an open bite on the right-hand side of his mouth there. And you can see how the lower jaw is starting to change shape as well, with the teeth starting to unravel themselves. And between these two photos, that's not the final photos of him, by the way. What I had done so far between these two sets of photos are just the MyoFocus takeoff program and the lingual frenotomy itself. So during the MyoFocus takeoff program, we, at the beginning, at the first visit of the takeoff program, we introduced the Myomunchee. So we got him straight away to to start improving all the chewing and the tongue function and the lips closure, plus giving him all the OMT exercises according to the prescriptions. And so after 4 weeks of the takeoff program, in which we saw him once a week, then after that first 4 weeks, we actually released his lingual restriction and continued on with another 4 weeks of takeoff program. So the initial 4 weeks before the lingual restriction release itself is what we call the prehabilitation before the tongue-tie release, and then it's a rehabilitation of the tongue-tie release. And that initial 8 weeks with the tongue-tie becomes a total of 9 weeks. So the differences in the two sets of photos are over 9 weeks of treatment. And after 9 weeks of treatment, that's when we introduced the MyoBrace K1. And now there are 3 sets of photos here. So there's August 2018 before we did anything, October 2018 when we completed the takeoff and the lingual frenotomy, and January 2019 was when we started the MyoBrace K2. So he just completed his actual stage with the MyoBrace K1. And when he was doing the MyoBrace, he continued on having the OMT prescription. So every time he would come to see us, we would give him about 6 to 7 types of different OMT exercises that would address not just the tongue, not just the lips, not just the cheeks, not just the breathing, not just the swallowing, but trying to address all of them in one. Every time we address all the dysfunctions, but paying particular attention to what's the most significant dysfunction at that time for the patient. So you can see in January 2019, the development of the jaws are even more significant, and his occlusion is starting to unravel themselves even better. And you can see that lower right side canine, adult canine tooth is going into the dental arch alignment now. And this is all continuing with the orofacial myofunctional therapy itself, and for him to practice all the exercises 3 times a day as well. And so that was January 2019, and we completed his active treatment in June 2019. And you could see his postural photos. He's still got a bit of a head tilt then, which the body worker is working on, continuing to work for him. But look at his facial profile, where his head posture actually is. You know, his neck is even in better position. He's got very competent lips still, and his smile is actually looking more normal, more ideal, I suppose. And when we look at his dental arches, the occlusion got even better and better, and the alignment of those teeth are actually fitting in quite nicely, to a point where I am actually not as worried anymore in terms of whether he would need braces or aligners or not at in a few years' time. So at the end, if he decided to have braces or aligners, that would be pretty much a decision that him or his parents can make later on. But to me, that result at the end of the active treatment and seeing where the original photos were, where he came from, that is, I think that's quite good. I wouldn't say orthodontically perfect, but I think it's quite good. And but myofunctionally, he's got really improved, corrected, and stable orofacial functions in terms of swallowing, breathing, and everything. And by the end of that, he could actually hold a conversation with me and look at me in the eye as well. So it works not only just on functions, but neurologically, and you know, his growth, his development, his behavior, everything has really, really changed. Any questions so far?
No, but we're already starting a side conversation on how we can like sign up for the takeoff program.
Sorry, I can't see your chats on my screen. Yeah.
Yeah.
All right, I'll continue on with the 2-year-old case. So the 2-year-old case, I saw this boy about a year ago or so. Just like Sharon, the youngest that I've actually prescribed a Myomunchee for was 18 months old. And it was more difficult to take photos on an 18-month-old, and they all didn't turn out that focused. So the best photo I've got is of a 2-year-old here. And this 2-year-old came to see me, and as everyone can see, there's quite a significant anterior overbite, open bite, which was actually caused by a pacifier habit. And the parents eliminated the pacifier at 18 months of age, but then he replaced the pacifier with his tongue. So his tongue was just thrusting in between the teeth all the time. And I could even see him before he even walked into the consult room, as he was still waiting in the waiting room. And look, most of the time when I look at a patient is what their behavior is like in the waiting room. That's probably when the best time that you can gauge what their posture is like and what their normal dysfunction. That's when you can pick it up, because you're not telling them to, hey Joey, can you do a swallow for me? Because it would be more staged, the swallow. So I tend to make a lot of the observations even when I call the patients in from the waiting room, and I start to work on the compliance as well in the waiting room, trying to build up the rapport and the relationship with the patient right from there. And so, sorry, I went off track a bit. But with the pacifier and the tongue thrusting, that's obviously resulted in keeping the open bite open and preventing the jaws and the teeth from growing towards each other. So with toddlers this age, when I prescribe a Myomunchee, I would always try to take photos, and I would always get the parents to come back every 6 months, where I would take progress photos as well, so that we can see the changes. Because even I know with my own kids, for example, I see them every day, and oftentimes I can't see what's changing, and they're on my brace and they're doing OMT as well. So when I brought this boy back, and he actually came back 5 months later, the mother said to me, the first thing that she said to me was, "Oh, it didn't work at all." She said, it didn't work, and he was actually munching on the munchie for 20 minutes a day, and he was associating the munchie with having a bath, because he loved doing having a bath. So his mom said, if you want to have a bath, you've got to munch on the munchie. So he would munch on the munchie 20 minutes every day. So his mother came back and said that nothing happened. There's no change at all. And so I actually took the photos and showed her, and I can't swear on this forum, but she actually said a word that shocked me. And so she basically just couldn't see the changes, because she was looking at him every day. And you could see how much the open bite had actually closed because of the munchie, but not only because of that, it's because I also got him to do the end spot exercise and the tongue clicks. So what I wanted was for the tongue to not be thrusting forward anymore, and having that aim of elevating and strengthening the tongue up towards the palate. And when the tongue started to go up and elevate towards the palate, obviously everything else, if the function is corrected, all the form is just going to follow, because form follows function. So for a 2-year-old, it was easy enough to teach him an end spot exercise and tongue clicks. So end spot is like N, 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 and just got him to copy me, and teach the parents as well to make sure that they know for him to copy them as well. And tongue clicks is just clicking the tongue against the palate. So I got him to do all these at least once, twice a day, whenever they can, and also still munching on the munchie for the aim was 10 minutes twice a day, but he managed to do it for 20 minutes total every day. So they came about 5 months in between visits. So in that 5 months, obviously the tongue has been, the tongue thrusting was corrected, but the work's not done yet because he was, by the time I saw him, he was about 2.5 years old. And by the time he's 5.5, 6 years old, what we want to see is we would like to see a lot more gaps between his deciduous dentition and having more of an edge-to-edge bite with the canine tips quite worn down around 5.5 years of age. So I'm continuing him on the Myomunchee, and I would probably start to give him more and more challenging exercises as he gets older and continue on to take progress photos and then see where he's at when he's 5.5, 6 years old, and see whether he would still need orofacial myofunctional periodontic therapy. But we'll see if he continues on to be so compliant and things are progressing towards the right direction, then obviously the risks are getting reduced as he gets older. So those are the two cases that we've just discussed, that we usually talk about during our OMT course and our mini residency course. So we've just had our OMT course, as I mentioned, over the weekend, but stay tuned and get connected with us through our Facebook page, the course's Facebook page as well, so that you can get updated in terms of when we release dates for our next OMT course. And our next MyoFocus Mini Residency is actually in Sydney in May 2020. But as Dr. Dan said, we do have our MyoCPD online learning platform, in which the mini residency is about to start on the 1st of September. And we will, from time to time, put our OMT course into the online learning platform as well. Thank you for listening. And if there's any questions, please feel free.
Yes, much. Please feel free to type your questions in the chat box, or if you would like to ask the questions directly to Dr. Donnie. Thank you for sharing the awesome cases. Actually, personally, for myself, bath time is the best time for me to chew my munchies too. Yeah, I find it most effective use of my time. And
right. You don't sing in the bath, Louisa?
No, don't have the habit. Yeah, but now I know about the pussycat chomping, so I'm gonna have to practice the pussycat because I dinosaur, and then I realized that I was over chomping, so then I think I reduced it to the rabbit chomp, so now I have to up my chew. Yeah, but I'm wearing Invisalign now, and
Me too, actually.
Yeah, and it really helps. You know, every time I put on my aligners, in goes my munchie to help seat the aligners. So that's another fantastic way of using the munchies.
Correct. Yeah.
Yes. Yeah. So practitioners on the Zoom, do you have any questions for Dr. Donnie? Yep. So really what we were chatting in the group was how we really love to bring you guys over one day to Singapore. Hopefully not too long. I think as we grow the community in Asia, we're gonna soon have enough numbers to be able to form that class. Yeah, we'll be really hope to be able to bring like at least the tip of program, because for the OMT they can sign up for the online course. Yeah, so any questions so far from anyone else? You'll be able to stay on till the end, right? I guess we still have about 10 to 15 more minutes. Yeah. So
yeah, no problem.
yeah, thank you. Dr. Irene, are you around?
Yes, hi, I'm here.
Yes. Hello, hi.
Hi.
Are you able to turn on your video?
Yes. Hi.
Hi, hello. Oh, you're still in your practice.
I am, yes.
Oh,
And I just want to say I've signed up for Dan's class yesterday.
Oh, cool. Yeah. I still remember when we were meeting face to face in Singapore during the TERF Steno Sleep Medicine course, and you were sharing with me the amazing story with your own patients. And
Yes.
I thought, I would really love, for you to share your stories, and how you've had, how long you've had your journey with the myomycete and how it has been so far. So Dr. Irene Lau is a pediatric dentist based in Hong Kong. And sorry, Dr. Irene, I'll just say a quick goodbye to Dr. Dan. He says he's heading off now because he has to wake up in 6 hours.
Thank
So,
you.
yeah, thank you, Dan. And I hope that this isn't the last that we see of you on our study club session. Thank you for sharing so generously.
Thank you so much. Yeah, thank you all for listening, and I'll let you all get on with it. And I look forward to watching the bits that I miss, because it's been great to listen to all the conversation so far. Thank you.
Thank you. Good night.
Bye.
Yes, Dr. Irene.
Yes, so I'm still quite a newbie in the Myomunchee, but I started my first Myomunchee case about 9 months ago. I don't have it on slides, so I have photos. I just don't know how do I share these photos on here.
Okay, at the base of your, at the last row, do you see a box with an arrow that says share?
Yeah.
Yeah, if you click on that, it's supposed to allow you to share your screen. Do you see that? Is that happening for you?
So are you seeing anything? What do I click on?
Yeah, I think if you click on it, and then you're supposed to click on the screen that you want to show.
Yeah.
I still am seeing your beautiful face.
Oh.
Yeah.
Okay.
Yeah.
You see anything?
It's starting. Yes.
Okay. So you see two photos.
Yes.
Right. So I don't have the first photo. So this case is over a span of 9 months. So the first photo, the first time she came in, she had a really deep overbite. This girl was about 4 years old when I saw her. So she wore it she was munching on this 2 times a day for about 3 months. And the bite had risen up. So there's only about 20% overbite now. She was initially, when she started, it was about 80% overbite. And then she started sleeping with this Myomunchee for another 3 months. And then, so we could see the second photo where the midline had aligned also. So I found it quite impressive. Then I started off with other children, correcting their habits. So I have a lot of younger kids in my practice. And I think this one. This is another one where she was thumb sucking and overbite, open bite, anterior open bite. And so I had gave her the Myomunchee to replace the habit. And this is just, a month and a half later, she lost her lower anterior. But we could see the bite had closed up a bit. And she stopped the habit. She completely replaced the thumb with the Myomunchee. So I thought it was quite nice. But I do have a lot of cases that are actually not quite successful replacing the habit. I don't know if they're too young or parents are not helping the kids. And then I have another one here. Not this one, Charlotte. So with Charlotte, I couldn't get nice photos on her the first time. But we could see number 5-2 is in crossbite. And over a month of munching, because she also had a functional shift. She closed down. And I think over a month and a half or maybe 2 months of chewing, 5-2 came out. a bit. She's still chewing now, so I haven't seen her yet. We'll see how it works. But she also has a unilateral crossbite. I was thinking of putting in an expander for her. I don't know what your thoughts on that is, because I've been following Dr. Audrey's cases, and I thought maybe putting an expander would help also. Any thoughts on it?
Dr. Donnie?
I wouldn't put an expander right from the very beginning. So I would actually concentrate more on the orofacial myofunctional therapy and see what happens. You may want to start introducing a myo brace as well. And a lot of the times at this age group, they may actually resolve because the dysfunction is corrected, and you may be able to avoid using extra appliances like the expansion appliance and all that. So as you could see from my previous case with the 10-year-old, even I was thinking even expander as well, and ended up not really needing that.
Doctor,
Thank you. Yeah.
I trouble you to move back to unshare your screen.
Unshare my screen. Yes. Or stop share. Here you go.
So we can see one another's faces. Great. Dr. Donnie, earlier on, Dr. Irene was mentioning about the not so successful cases, right? In your practice experience, what could be some of the possible reasons why it's not successful, and what do you do with these cases?
So in my experience, basically it's very, very important to get the parents on board and to make sure that the parents understand why. So the way that I've always practiced is not only it's about how it's not only how we explain it to the parents as well, but about the whole picture. So I always design my practice according to compliance because I love treating kids. For example, with my practices, we don't really have, like the patients don't actually go into a room with a dental chair as an initial consult. It's always just a consult room. And most of the time they don't actually see a dental chair until, later on in the visits when they're actually well and truly in the treatment itself. So when you have that type of surrounding and setting and environment that actually makes the parents calm, not just the children here, the children can pick it up actually. So when we designed MyoFocus first time, we actually had an interior designer that wanted to put lots of different colors, rainbow and everything, because she was thinking it was a pediatric practice. But what we believed was if the parents are calm and the parents walking in and their anxiety is gone, then the kids would pick that up. So we actually decided to go with more of warm, earthy colors. And that's what we've been finding. The children that walk in are actually less playing up, I suppose, and they enjoy coming into the MyoFocus waiting room as well, because there's a lot of toys that they can explore with their hands. It's all wooden toys that encourage them to just use their hands, use their feet, and even our exercise room is adjacent to the waiting room, so they can see other kids doing their exercises. And the exercises is not just about the face as well. We do teach them postural exercises as guided by our pediatric neurodevelopmental chiropractor as well. So compliance with me is from the very, very beginning. It's not just about when you're actually having the consult and doing the treatment with the patient. So it has to be an experience right from the very start, right from the first time that they walk through your clinic door. And even during the consult room, we Dr. Dan showed a photo before of the consult room where there's no hint of dentistry at all in our consult room, basically. So we even have a really nice big armchair, which the kids tend to choose that chair when they walk in, you know, and I would play with them. I would say, wow, you must be so clever because you chose the best chair in the room. And that chair is also actually the breastfeeding chair for the mums when we do infant clinics as well. So compliance is all about setting everything correctly and making sure that the family is all comfortable and are given the opportunity to be able to listen and to understand and to learn the reasons why these issues are happening, because they're already coming in with an issue. They already know what the issues are. But it's our responsibility to be able to explain why, and if they understand why, and if they understand that there's a certain window of opportunity that they have to be able to address the why, then they're more likely to be compliant. And the patient needs to understand that too. So parents, patient need to understand this. The whole family needs to be involved. And when we teach them orofacial myofunctional therapy, we make sure that the parents know how to do these exercises as well. And it's not only because we want the parents to be able to do them and make sure that they know what the patients are doing, but we want the parents to actually be able to check on their children when they're doing it properly, because it's the parents who needs to set the schedule and the routine every day for the patients, for their own children, right? We're not there living with them every day. So it's a whole, I suppose, it's a whole big picture thing in terms of compliance. And, you know, I used to work in a general practice where there's no consult room and everything. And yes, my compliance level was very low because the first consult, the first treatment, everything, they have to sit on a dental chair. You know, if you have a dental chair with the dental cart, the hand pieces with the light, with the spittoon, everything attached to it, that's, you know, the first impression is already not great for the families.
Okay. So I think really the key message is to improve compliance is really to involve the whole family, especially the caregiver, right? And that's when you will get a higher success rate. Yeah, thank you for that. And thank you, Dr. Irene, because this is really what we hope to be seeing, like practitioners like yourself, even though you're relatively new to, you know, utilizing the Munchee, that, you know, coming out and sharing your success cases so that, you know, you can continue to inspire the rest of our users out there. Yeah, and
Thanks for introducing the Munchee to me. It was through you guys, I think. That's how I started using it.
we always share the good things that we find around the world, right? Yeah. And for me, yeah, the value of the Munchee over like the previous systems that we were using was the MyoBrace, like most of us, right? And while it has its position and place, it was still like a very passive device, and it had definitely to be coupled with, you know, myofunctional therapy for it to really work. But the beauty of the Myomunchee is that it is an active device, but it can be a passive one, like when you got your, you know, when the 2-year-old wears it overnight. So you can choose for it to be active or passive, and it's great for the young kids especially, right? And as a first device, you know, like in the takeoff program, you know, as an initiator to devices in general. And I remember Nathan even shared that at MyoFocus, I think it was like if they take to the Myomunchee, then you even progress them to other appliances, right? And it was like the initial test, right, of compliance, even. Yeah. Right.
That's true, because at the 4-week mark, if their compliance is not so great, then we've got to think about other strategies. But it's quite rare that happened in MyoFocus because of all the things that I've talked about already.
And as an added bonus, really, I think the Myomunchee was initially designed as a hygiene brush, right? And if anything, you know, they're also cleaning their teeth while they're chewing on it to a certain extent, right? And I think it's just such a beautiful multifunctional device for the practitioners who are still, you know, on the Zoom session. Perhaps I would like everyone to just share like maybe some of the insights that you have gained from tonight's session. You can either type in the chat box here and I can read it out, or perhaps you can unmute yourself and share. Would anyone like to share just a short sentence or two, like the key insights that you've gained from tonight's we're so honored because we have so many experienced practitioners all on one night sharing with us. So really thank you so much for your time. It's especially late in Australia, really. Thank you so much. Thank you, Dr. Irene, for sharing also. Yes, someone shared that, the pussycat chewing was the the key takeaway. Okay. Yes, that's from Yenna. Yeah. And anyone else would like to share their insights? I learned so much, and I was like madly taking notes. Like I have lots of pages of notes, and I think I still need to go and do a playback later on and really consolidate all of the good tips that I've had.
Can I just say something?
Yes, Nathan.
I'm just really impressed that you find time to have a bath.
What do you mean?
You said that you chewed the munchie in the bath. I'm actually just impressed that with all the things that you do, that you actually find time to have a bath.
Oh, really? Okay, I'll take that as a compliment. But yes, I think that's a necessary thing in a very hot Singapore.
Yeah, absolutely. And it's a really good point. You find the time that there's something that you do regularly, and then you add the munchie to it. I'm really impressed with the flexibility and the way in which the munchie does integrate.
Yes.
And really impressed with the practitioners that I've been working with over the last couple of years, how they themselves have actually found new and unique ways to use the munchie, and especially ways which we never even considered in the past, coming directly from munchie.
Yes.
So it's been a real testament of how integrative, how flexible, how versatile. Can't think of enough words, but the simplicity of it all can make some massive differences. So much so, we've actually changed our new tagline to small device, big impacts.
Love that. Yeah.
Yeah, so we are making a really big impact with so many people around the world, and we're really grateful for everybody that's come along here to participate with us. And keep doing what you do.
No, I mean, if you really look at the history of the Myomunchee, right? I mean, it is the precursor of a lot of the appliances that we have out there. It was initially designed as a good alternative to the toothbrush, but then Dr. Kevin Burke realized that it was actually doing a lot of good craniofacial work for the kids, and I think that evolution of how this device came about, the evolution story already just shows how it has so much room for creativity, like you say, right? And now practitioners around the world are just taking it away. It has so much room for you to just turn it into something that is so it can be both active and passive, and okay, another sharing from Yenna. One of my clients is chewing on munchie when he's sitting on the toilet and reading. A 7-year-old boy. I guess as long as they're using it, right? At home we bargain with Shay. He's 9 years old. If you just ask him to chew on it, no, it's not gonna happen. So it's like his iPad time has to come with a munchie chewing time. It's kind of like so if you want to play a game 10 minutes, then you have to chew for 10 minutes. So sometimes we have to do this kind of bargaining. Dr. Pang shared that I like the treatment flow shared by Dan, Sharon, and Donnie, very systematic. Yes, and really, I encourage you, if you are new to pre-orthodontic treatment, then their mini residency course online would be a very good one, where they've really shown you just a tip of the iceberg. Yeah, so theirs is a very comprehensive course. They've got years of experience, in this myofunctional therapy, and to think that you get the full program for 2 months. Because usually when you attend a mini residency, it's like 4 days of crammed information. So this one you have 8 weeks, right, to digest, and at the end of it, a forum to ask questions and further that deepen that understanding. I think I think that would be a very great course.
Can I just add, Louisa, if I may? So the online mini residency is where you get the forum, and yes, you're right, it's over the 2 months. But when you attend the live mini residency, which is over 4 days, you actually get an extra day, which is the 5th day, in which you get to spend a whole day observing us at the MyoFocus Melbourne flagship clinic, and you're allowed to bring 4 to 5 members of your team as well, so a total of 5 to 6 people. And we would only accept one clinic at a time during the observation day. So we've had quite a few graduates from the mini residency, because we've done the mini residency 2 years in a row now. So we had quite a few graduates who brought their whole team, and that's when they actually learn most, because they're seeing things being practiced live, you see. So it could be quite a valuable experience. Yeah. But that's only the live 4-day mini residency, not the online session. Yeah.
Consider, like, if you do online, right, can we add on, and then just come for observation? We'll discuss that. Yeah, but I really hope to be able to also one day bring you over to Singapore, because I'm not biased because I'm Singaporean, but I think Singapore's quite central, to all the different countries, and we still now don't have. I mean, we have smatterings of practitioners all over Asia, so I think I would one day be able to host all of you here and have everyone meet here and listen to you live. And Dr. YC Kong says, I can see that a nice prescription of OMT together with reasonable timing on review and monitoring is very important for success. What you've shown is how you have a very successful workflow. I think always case sharings by experienced practitioners like yourselves is just an inspiration for new users, because they can see how you have brought someone right from through and that it's real, it's for real, and that it works. And but of course all the different elements have to be in place, like I said. Very important. Yes. Right.
I like to thank you, Louisa, if I can, to invite Dan and myself to join tonight's study club, because amongst all our busy schedules, for some reason that tonight just worked out. Yes. And thanks for letting me have a little break to tuck my daughter in just before, because I'm alone at home. My wife's away with my other daughter in Sydney, so for their commitments and stuff. So it's great, and it's great to be able to share a little bit about MyoFocus with you all, and meet you online, I suppose, and hopefully to meet you all live one day, face to face. Yeah, so it's awesome. Thank you so much, Lisa.
No, I think both of you, have been doing an incredible amount of work, right, in pushing forth this whole revolution, really, in how we are, treating, from the beginning, right, from right. I mean, you see babies for tongue tie releases too, and and then you see them through the whole phases of their lives, and I think we just need to get more practitioners on board to understand the enormity of this task, right? And how we are just, the earlier we help the children, then we are really preventing a lot of things that can happen later on. A more drastic form of surgery, or and I think the cases that you have shown have been amazing and truly inspiring. And
thank you.
Thank you. We're really honored to have you, and we hope that this isn't the last time that we see you on.
The honor is ours, Louisa. The honor is ours. Thank you so much.
Thank you. Yeah. So, everyone who's on this study club, if you still have any more questions for Dr. Dan and Donnie, Sharon, or Dr. Irene Lau, so feel free to share on the WhatsApp group, and we can always we're really good friends with them, so I'm sure they will they will agree to come on at some point in time again, to answer all the questions. So thank you once again, and any last parting words? Otherwise, it's already 8:15, and 8:15 in Asia, but 10:15 in Australia. So I think it's time. Our guests go to bed too. Yeah. So thank you so much, everyone. And we will fix the next session roughly about 6 to 8 weeks. In 6 to 8 weeks' time. We do intend to keep this study club a constant going on. And thank you, Dr. Irene, for sharing your cases. And I hope that there will be more new practitioners. No matter how simple, sometimes it's the sharing of the small wins, right? That does that give that motivation, and then you can do that more and more. So I hope that more people would come forward and just text me and share, that I've got a case that I want to share during the next study club session. And we will definitely make time. I think it's all the more valuable if you're a new user and you have seen the success cases. And some of these success cases, we realize it could just take as short as like 3 to 4 months, and you're seeing amazing results. Yep. I guess the only tricky part is for very young children, it's always very hard to get a good photo. Yeah. So yes.
Excellent.
Thank you, and have a good night, everyone. And
thank you, Louisa.
Other questions?
Good night, everyone.
Contact. Yeah. Okay. Good night.